So,
So
first of
there
all,
we are.
Giancarlo, thanks so much for accepting to do this interview.
Thank you so much for inviting me.
You've done a lot of contributions with your metacognitive interpersonal model, with
Yeah.
dialogical self theory, but I would
Hmm.
like to always try to go a little bit back and to know a
Yeah.
little bit more about you.
Yeah.
So let's go way back, and I just wanted to ask you what drew you into psychiatry and psychotherapy in the first place?
Oh my goodness, I wasn't ready for such a personal
Time
question.
machine!
I think nothing pleasant, nothing beautiful. I
Oh,
think it's mostly, I think about personal needs to make sense of interpersonal relationship, and probably to find some source of explanation for things that made me suffer personally. Of course, in the very first years of my studies and practice, I was looking for a theoretical explanation, kind of giving an order to psychological madness, to insanity around me. And of course, I just later realized that it was my personal insanity. But it took quite a while to realize it. And so I realized just after some time that it was about some personal needs. Then, of course, I was much curious about psychological states, and what I ended up being probably is kind of strange, bizarre. Actualization of what I hoped to become when I was a kid. I wanted to be a scientist.
mm-hmm.
Then I realized that hard sciences was not so much for me.
Mm-hmm.
So I found my way in between, science and humanistic disciplines.
Yeah.
So I don't know if I answered you, but
You answered
these are
perfectly. I think,
some.
a lot you're saying it out loud. I think a lot of people share that guide to go to this field because of those issues.
Yeah.
Yeah. So, and your interest in personality disorders also came very early, you would say?
Yes, yes. Well, as soon as I started, I am a psychotherapist. I define myself as a psychotherapist, but my background is from psychiatry.
Yeah.
Uh, if I had the chance to rewrite my life, probably I wouldn't be here. And my hope was to be a writer, a storyteller, but probably I had more talent if I had talent to do this. So I don't know what would have happened. But actually, I'm a psychiatrist.
Yeah.
And when I was having my psychiatry specialization, I came in contact with family dynamics and interpersonal psychoanalysis.
Yeah.
And I realized that I was much interested into that.
Uh-huh.
And so basically, I was very interested in the interpersonal roots of human suffering,
Yeah, yeah, yeah. Uh-huh.
what is called interpersonal schemas, mostly. Whatever you may prefer to call them. So may them be object relationship, self-other others, internalized working model of attachment, role relationship, whatever.
Mm-hmm.
But that my very interested was there. And my first interest in the field of personality disorder was in narcissistic personality disorder.
Yeah.
And I refuse to answer to any question
Related to as to why.
about such a choice.
I won't put you in that position. But
You can, but I will call my lawyer, and I will call the Fifth Amendment. I don't know.
don't worry, I won't put you in that position. But it is, it's interesting because in the past you said that you don't really particularly enjoy the idea of personality disorder, and that you would even much rather have the idea of personality malfunction.
Yeah.
Yeah. Can you just explain why?
Yes. No. That's good. And of course, personality disorders fits the concept that people have problem in personality. That is the way they relate to themselves to others, the self-concept, the way they are driven to do something in their life. But basically, when you think in terms of personality disorders, you think in terms of something that is crystallized. That people will function in a stable way. over the years. What you can observe when talking with a client for years, which is what you need to do when you treat personality disorders, is that you discover that in different periods, sometimes even in the same session, you observe different ways of functioning.
Yeah.
That is, the same person may function in a way that may appear, don't know, narcissistic. 10 minutes later, when talking about the breaking up of the relationship with the lover, not the official partner, I mean the lover, and they function as dependent personalities. Okay, so it's a way, it's cycles of functioning that alternates with each other, and this is not captured by classifications.
Yeah.
It wasn't captured by the categorical classification. It is even less captured by traits.
Yeah.
Because traits are supposed to be stable.
Yeah.
Yes, but you can observe a person with avoidant personality disorder being very shy and introverted and afraid of criticism, but with time they may become arrogant, aggressive, spiteful. It's the same person. And you cannot explain that switch, which happens in clinical observation, simply resulting to stable disposition.
Yeah.
So if you instead think in terms of functioning, which is fueled by different domains of psychology, of psychopathology, of different areas which combine with each other, then you can understand what really happens.
So that's really interesting what you're saying, and I feel that without this concept of states or modes, whatever you want to call them, that you can understand how the study of personality disorders, even clinically, can be a huge chaos, because at the sudden you can't understand what's going on. Like, I thought I knew what I had in front of me, but all of a sudden it doesn't fit the categorization. So
absolutely. I think this is captured even, of course, by skilled clinicians who didn't devote their attention to personality disorders. For example, I'm thinking in particular to some of the guys who had a biggest impact on my training and experience. I mean, the model of solving, repairing alliance rupture by the late Jeremy Safran and Chris Moran. And they clearly say, you deliver an intervention to a person, but the person who reacts to that intervention is a different one.
Yeah.
So you don't know who you are talking to next. So if you have a model of the self as multifaceted, and so with different areas of personality of the self, you can name them voices, positions, characters, self-objects, objects, whatever, again, you can make sense of these sudden switches. And so you are ready to react not to the person you've spoken to, but to the person that is answering to your observation.
Yeah. So here you're already speaking to your interest in multiplicity of self and dialogical self theory. But just before going to that, I would just like to ask you, because in the early 90s you were very influenced by the narrative and constructivist movement. Of course, Jeremy, Safran, and Moran. And at the same time, you did have this interest in nosologic, or at least in diagnostic criteria. Was it hard, at least early in your career, to be able to integrate these two types of thinking? Because a lot of people would think they are at odds with each other.
I understand that. Yes, not to me, but I had to face some difficulties. Which means facing hostile reviewers in fields.
Surviving the reviewers.
Survive the reviewers, which is some of the part that makes you stronger over the years.
Good.
But yes, mostly I never had problems at the theory level about that. But of course, this needs an explanation. Actually, I still define myself as a constructivistic narrative therapist, by the way. Of course, it's not more about George Kelly, but it is about minding that clients suffer because of their constructions, not because of the reality, at least to a certain extent, and that people need to construct stories about who they are in life in order to make sense and ground a sense of identity. But this points to minding about the person, and minding about the unique story that every client tells you. And so, thinking in terms of the specific functioning of that person, which is what I actually do now. That is, in our work with metacognitive interpersonal therapy, and in particular in the next book we have just finished the Italian edition, which will be issued in next March.
Congratulations!
And we are about to submit the proposal to Routledge once the sample chapters are ready, and they are almost. And we don't think much in terms of categories, but in terms of formulation of functioning. So we put the ingredients, the ingredients of psychopathology in the mixer, and then we came with an idea of overall functioning. Okay, so it is more a tailored, custom-made, client-tailored formulation of functioning. But no matter how constructive one can be, one has always to be aware that human mind functions in terms of categories.
Yeah.
Even if you refuse them, you use them.
It's a good sentence.
And
so you can find stable processes, is what you're saying.
First, you cannot avoid them.
Yeah.
Even the ones who are less, who dislike categories, they use categories. They simply use broad ones, which convey less sense. Then you need to find similarities among clients in order to convey knowledge, to transmit knowledge to colleagues and the next generation.
Yeah.
Okay, so you have to find clusters of functioning and similarities. I don't know why, but I think there is some political issues there, but probably the model that makes more sense in terms of personality is the one by Drew Weston and Jonathan Shedler, so which is the one created with the swap. And it works because it describes broad patterns of functioning. It's not categories, but it is stable patterns of functioning. And it has been neglected in the rewriting of the diagnostic manuals. So,
considering the model itself, metacognitive interpersonal therapy, I can see that there's already news, and the new books are ready to be published in a way.
Yeah.
Around what era, again going back a little, did you feel that you had at least a sort of coherent framework to actually, build a model? When did this happen?
Yeah, but it did happen. I very clear the different steps. First, there was my background studying a lot in the field of interpersonal psychoanalysis, self-psychology, intersubjectivity. So Stephen Mitchell, Harris Tax-Sullivan was a very early influence, which I never acknowledged, but I know it's there. And family therapy was important, and of course my early mentor Antonio Semerari. The idea that therapies for severe clients needs to be accustomed to problems with metacognition is by him, is by Antonio, and of course this is much inspired by Peter Fonagy. And the concept of mentalization, and at least to the same extent by the work on assimilation of problematic experience by my friend Bill Stiles. And Bill has been a great source of inspiration and help and support over the years. And I want, so if he listens to the interview, he knows that I'm mentioning.
You acknowledge him.
So Bill has been a great influence and a partner also for some works. And then one very relevant talk was one I listened by Bob Niemeyer in 1999, and it was about narrative disruptions. That was the one that made me understand, well, I have to focus on narrative disruptions. That was a great source of inspiration.
When was this?
In 1999.
Okay.
Then the work by Giovanni Leotti, because he wrote a book in Italian, but then many papers in English about borderline personality disorder and disorganized attachment. And I was impressed by the way he could put different phenomena into a coherent framework of functioning.
Yeah.
Okay. So with Antonio Semerari and my former colleagues, the interest was more in disrupted metacognition and interpersonal cycles, which is the concept delivered by Safran and Siegel at the beginning. So you interact with persons in a way that deteriorates the relationship. And then I was in Siena for a conference. I think I don't remember if it was on cognitive or constructivist other psychotherapists, I think. And then I realized that we needed a model of personality functioning, combining different elements of psychopathology, most notably metacognition, interpersonal cycles, and bias reasoning. Okay, these were the main ingredients, and disruptions at narrative level. So I tried to combine a model of functioning, which I then published in many. I started with a model of narcissism, which was published in 2002 by the Journal of Psychotherapy Integration. And then expanded to the whole area of personality disorders. So that was the beginning of the early foundations of metacognitive interpersonal therapy.
A lot of influences.
A lot.
Fantastic.
Yes. That is why I still define it an integrative psychotherapy.
Yeah. Well, maybe just to give people a taste of a distinctive feature, I find it interesting. Well, you have always described it as a narrative model, and you have written multiple times that in this approach you always struggle, maybe from the first to the last session, to try to get to elicit specific autobiographical memories or episodes. And this seems like such an important feature. I'd like to invite you to elaborate on the importance of this, of eliciting specific autobiographical memories. You don't work with vagueness. You don't work with until you find.
No, absolutely. I don't. I'm very little. I have very little interest in the way people think. Their concept of the word. It's pointless. It's just boring. I can be interested when I listen to some good a late night show, some nice interview. People have something to say, but I am hardly interested in the thing I think. And so but basically, what I think is that meaning making, you can find meaning making soon before action. Because the way people act is influenced by what people think. And thoughts and feelings are relevant to the point that they influence behaviors and somatic states. Okay, and you don't find them in the overarching narrative. You find them yesterday, this morning, tomorrow, the other week, when you were 5, 6, 10, that day. Okay, so I can think I like a certain thing, or I want to take care of persons around. Okay, this is my value, for example. Okay, but if I tell you my story, not my personal story, by the way, I can think of memories in which I wanted to do something that I liked. Go and play football, go to a university in the other town. That was my very goal. But that day I told my mother, well, Mom, I will move out of town in order to study psychology or play in a football team or whatever. And she reacted with a huge headache. She felt bad. And then my father was disappointed. You're betraying the family. Okay. And then as a coping strategies, I had to take care of them, which is inverted attachment, by the way. And my motive for autonomy and exploration is shut down. Okay. But I can find the very sense, the felt sense of personal experience, when I retrieve that memory and possibly reenact them.
Yeah.
So please tell me what happened that day when you talked to your mother, when you faced your father, when you try to make good reasons for pursuing your goal,
Yeah.
but then they reacted that way and you felt what?
Mm-hmm.
At that point, your initial story is disappeared and you have a completely different one, which is the one that has power over your life,
Yeah.
and controls action. Okay, so if you want to find relevant information, you have to scan for detailed episodes.
So this is really cool, Giancarlo, because one thing that I found very helpful in studying your model is
Yeah.
that actually a lot of people, I think, when they think of schemas, and I learned this about schemas, they think more of generalizations, like
Yeah.
I am unlovable, people are not to be
Yeah.
trusted, this kind of thing. And it was very interesting to read how you were influenced by Luborsky and Christophs to try to decompose the idea of schema into various components. And I think
Yeah.
you just laid out the components beautifully. So first there was supposedly a wish and
Yeah.
an attempt to do something, then the response of the other, and your coping of that response.
Yeah.
And it's very interesting because I was wondering if you could elaborate on this concept of the schema, because it seems that for you and in your model, it's very well decomposed into specific structures, and it needs to be decomposed.
It is.
Yeah.
That's a very relevant point. By the way, schemas has a cognitive component, but very often that cognitive component is an overgeneralization.
Yeah.
And people, to a certain extent, rely on them, but these generalizations don't convey what they actually do and why they do it.
Yeah, like the initial wish, for instance.
Exactly, but also the very the real self and other constructions.
Yeah,
they are not in their overarching model.
You can't take it too seriously.
No, you don't have to take them seriously. You just don't get anything from there. And also, there is more than Luborsky, because only recently I realized how much the work by Joseph Weiss and Harold Sampson, and formerly called Mount Zion and San Francisco Psychotherapy Group, influenced my work.
Yeah.
Actually, when Antonio Semerari delivered the training in cognitive psychotherapy, from which my first office was born, he had just written a book in Italian, very much influenced by Joseph Weiss.
Mm-hmm.
But then we just lost the early influence, and I just came in contact with some colleagues in Italy, Francesco Gazzillo. I will join a meeting with John Curtis tomorrow here in Italy, who is a member of the control mastery theory research group. And I realized how much that formulation influenced us.
Yeah.
Well, basically, how I frame a schema. Okay, there is the wish, evolutionarily shaped. These must be relevant wishes, things that, when unmet, cause suffering.
Yeah.
So social rank, exploration, attachment, group inclusion, sexuality, and so forth.
Is this synonymous in other experiential models when they look for the need, for instance?
Yes.
In a way.
To a large extent it is. Then you have to assume that there are at least a couple of underlying self-representation underlying the wish. For example, I want to be appreciated, which is social rank antagonism, and I have a core sense of self as unworthy, but I have at least a tiny part of me which thinks I'm worth something.
Yeah,
I deserve to be praised. Okay, so basically, we wrote this in the next book. Every schema is not a static structure; it is a test. It is a relational test. So I want to be appreciated. I have the need to be appreciated that day, and I want to face the reaction of the other, and I have two guesses at least. One is that the other will confirm my negative idea about myself, so he or she will criticize me, confirming that I'm unworthy, or hopefully the reaction will be positive.
And this
Okay, so
concern.
I will get the appreciation that I hope.
Yeah.
Okay, and consider that without such a complexity, there is no psychotherapy.
Yeah.
Because if you just have the schema of
I am unlovable.
unworthy, critical,
Yeah.
there is no psychotherapy because the story is written once and for all. So people don't show up into your room.
Yeah. So you tell
So
it more like a story that has a it's continuously asking for a new ending in a way.
I wouldn't say it better.
Uh-huh.
Exactly. Yeah.
So here you can see the influence of control mastery theory, the idea of the test.
Yeah. Exactly.
Yeah.
And also it is related to the work, early work by Dwight and Epson, which has been then continued by Miguel Gonsalves and his colleagues about innovative moments.
Yeah.
Which is very, it is something that is very close to the way I conceive the therapy process. Okay, so you have that story, but the story is at least to that extent open. Okay, so the goal of psychotherapy is, broad, enlarge that space. Okay, so the wish, underlying self-representation, representation of the other, critical, loving, caring, abusive, domineering, whatever, supportive, unsupportive, neglecting. When you face the reaction of the other in your imagination, because the schemas are predictions, or when you read the other reaction, then you have the response of the self. This is Luborsky.
Yeah.
Okay. The response of the self, it just activates one of the underlying self-representation. Okay. And then there is pain usually. Okay. Then the way people deal with that reaction
they cope,
is maladaptive coping usually.
Yeah.
So avoidance, submissiveness, aggression. For example, we are working with domestic offenders, both in Italy with one colleague in Verona and with in Australia. There is one colleague of mine, Dave Misso, in Brisbane, and we are trying to work with domestic offenders, at least the impulsive one, not premeditated aggression. You don't have way to deal with those people, by the way. And our goal is not to interrupt violence. Of course, that is the overarching goal. The very goal is tell me what happens, the narrative episode, soon before your aggressive reaction.
Yeah.
Because there is the response of the self to response of the other. And I want to understand what happens there and connect it to the schemas and regulate it in other ways than aggression.
Yeah.
Okay. So I want to deal with the antecedents of aggression. Okay, I don't know if it's clear enough, but
it is. It makes a lot of sense. It's interesting because I don't know if this will make sense to you. My own learning of personality disorders was very influenced to Orna Benjamin, and I know you've cited her quite a bit. And it's great to see, how you can deconstruct the interpersonal diagnosis in a way, in such a way that everything fits together. It's a very eloquent model.
That's our hope. That's what we struggle for to achieve, which is clarity.
Yeah. Well, in 2015, you published an article. It was called "Awareness of Maladaptive Interpersonal Schemas as a Core Element of Change in Psychotherapy for Personality Disorders."
Oh my God! I'm just ashamed by how long is the title.
Speaking of eloquence. Well, but still, it's interesting, because this at first view it seems common sense. Like, of course, we're always trying to promote awareness, but you argue in the paper in an interesting way that this isn't that much done in most models directed at personality disorders. The idea of promoting awareness of specific schemas and their components. Could you elaborate a little bit on this, maybe contrasting with maybe like dialectical behavior therapy or schema therapy? What do you find different in terms of this MIT type of promoting awareness?
Yeah. Well, there are similarities, by the way, with schema therapy. And I think we frame the schemas in different ways.
Yeah.
And we resort mostly on the very detailed narrative episodes. We don't use predefined schema modes. It is more tailor-made. We don't use standard names, the vulnerable, the healthy adult.
You have more of a constructivist standing in that.
Yes, absolutely. And when I listen to my colleagues say, "Okay, well, I brought up my vulnerable child," no, we don't do that. But of course, schema therapy is very good, and there are similarities. So it's more nuances. I won't go into that.
Sure.
I think more differences are in this respect with mentalization-based therapy. And by the way, Anthony Bateman has been an incredible source of inspiration to me, and he's a wonderful clinician. And I learned a lot from him, even in recent years. It's just that probably I think that to a certain extent they had to contrast the interpretative stance by, say, object relational theorists post-Melanie Klein in a certain extent. So they discarded the concept of schemas to a certain extent, or in a way to stable structure. So basically they don't use much that concept. We use it a lot.
Yeah.
Someone criticized us for, well, this may crystallize mentalizing. This is not true. At least not the way we understand schemas, because we don't understand generic, theoretical structure, but it comes from experience, from analysis of specific episodes. So we just put people in contact with the way they tend over the years to make meaning of interpersonal interaction in always the same ways.
Yeah.
So this opens mentalizing.
Yeah.
And probably, I think dialectical behavioral therapy is a bit different than what we do. Of course, we use a lot of regulatory strategies, but I don't think they have a concept of schemas. It's more about antecedents of maladaptive coping.
Yeah, more behavioral in that way. Yeah,
more behavioral and more. It is the way the chain analysis is very similar to the analysis of narrative episodes. Okay, it's just the way they reconstruct them, and they are more interested in stopping maladaptive coping.
Yeah.
We are more interested in rewriting the self-other schemas, and as a result, you interact coping.
Yeah, makes total sense.
Though we still use regulatory strategies, by the way.
This makes total, and it's one of my favorite sentences describing mentalization. Actually, comes from a title of an article of yours. It's a 2008 review. It's the "Know yourself and you shall know the other" to a certain extent.
To a certain extent, yeah.
So you do have also this bridge with Fonagy, but it seems that your therapy, at least not just in theory, but in technical terms, would look quite different, no?
Technically, it is different.
Yeah.
It is. There are many similarities in theory. There are many similarities in practice. But, for example, at least to my understanding of mentalization-based treatment, and of course, I can be criticized, and I would accept that. And they focus a bit more on mentalizing on the others. Actually, what we do is completely diverting attention from the mind of the other and putting a focus on mentalizing on the self. Okay, so I don't want my clients think more about their real husband, their real wife, their real boss, their real father, mother, whoever. But okay, this is what he said, this is what she did, but then you felt what, you thought what, and how is that typical of yours, and how is that connected to the way you make meaning? Okay, so we try to bring client to understanding that the way they make sense of interaction is mostly coming from their internalized structure, schemas, and mostly at pre-verbal level.
Yeah.
Okay. Once people are aware of their constructions, and they are aware to a certain extent they are constructions, then we make them reasoning on the other.
Yeah.
And also about the real others. Okay. Very typical. A woman with issues with separation issues, being left by her partner, usually described as a narcissist. This is a very common pattern. Okay. Well, we are not interested in him. But this evoked this kind of self states. How do you believe yourself in the ideas of being unlovable and unworthy and not entitled to pursue your own autonomous goals and plans and wishes. Okay, when people understand that they are the very first source of their invalidation, then they are ready to mentalize on the others.
Yeah.
Okay, for example, many clients, both men and women, by the way, after that phase, they start trying with new relationships, and this is a source of curiosity. So they can interact with new people, and we can observe schema-driven reactions, which reappear, by the way, and a true understanding of the other as the unique person. Okay, so then you mentalize on the other. But first you have to mentalize over your own constructions. Yes.
Yeah. And do you feel that this is kind of like a muscle, that it's something that is trainable? Like, what do you see as the mechanism that actually promotes this mentalization capacity?
Well, I think that there are two sides. No. It's totally consistent and straight to the point. Well, basically, there are two angles. One is, to a certain extent, there are people with problems, which are in a way poor ability. For example, people with schizophrenia, they have problems in mentalizing, which is connected to hardcore cognition.
Yeah.
Okay. And you can rehabilitate, you can train it, but to a certain extent. Of course, they will never, or the majority of them will never reach higher level. But there is much room to respond in psychotherapy. This is the work that, for example, is more than a friend and more than a colleague, is kind of a brother, Paul Lysaker, to me. He does that with schizophrenia. But there you face the metacognitive deficit.
Okay.
In personality disorder is much more like an atrophied capacity, and you have to train it. For example, what we do in metacognitive interpersonal therapy, especially in later formulation, and it has always been, but it is even more an experiential therapy. So you understand something in session, but then it's about doing something in between sessions and reflecting in the next session. So we always try to involve patients in you can call them homeworks, behavioral experiments, okay? But it is keep them active in order to have constantly new material available for self-reflection, okay? And there is the need for constant practice. You make some practice in session. Some practice very relevant is in minding about the therapy relationship, meta-communicating always Chris and Jeremy, and about the therapy relationship, making sense of what is happening between the two of us here and now.
Yeah.
But then there is a lot of, okay, you want to do that? Well, go to the gym, go to the office, try to get information about something you may like, talk with the secretary, back next session, and tell me how did you feel.
Yeah.
Okay.
So this is to promote awareness of the chain of events, of the interpersonal chain.
Constantly.
Yeah.
So a lot of behavioral experiments, but not because this is a behavioral therapy.
Yeah.
But yes.
And I'm thinking, and the meta-communication part from Jeremy and Chris, you're saying it also serves as kind of a corrective feedback to that loop, interpersonal schema loop, right?
Like, absolutely. Absolutely. Schemas get triggered in session, but then the therapists become curious and start I am realizing now that you are nervous, you are more withdrawn, like not willing to answer me. Is there something I said or did that was disappointing to you or created some trouble?
Yeah. What do you mean by the model being more and more experiential? How do you feel that the experiential component exists in session?
Well, we are doing more and more work, not so much at the level of talk,
Mm-hmm.
but using a lot of exercise like guided imagery and
Okay.
scripting,
Yeah.
and a lot of two-chair role play enactments which are coded. For example, we provoke clients. Of course, we told them in advance. I will do that to you. So explore how you will react. Adapted mindfulness. Tons of behavioral experiments,
Okay.
and so
Seems like an
we are.
intensive therapy.
Pardon?
Sounds intensive.
It is very intensive, but it is always negotiated.
Yeah.
Always. Whatever we do comes from a negotiation. So we don't do anything unless the client has given
Green
a
light.
visa. Yes.
Uh-huh.
Otherwise, okay, we explore a reason for not doing the task, but
Yeah.
we can stay steady and not doing anything until we don't have a specific contract for that task that day.
Yeah.
So the renegotiation of the therapy contract is a very important element of our therapy. Every session, the therapy contract is not something you draft in session one, and maybe you update it after some session. It's continuous.
Yeah. Especially in
So
personality
I
disorders.
think.
Yeah.
Pardon?
No, especially in personality disorders. There's
Absolutely,
a constant...
absolutely,
Yeah.
absolutely. For example, there are clients who can resist to everything that you do, and at a certain moment, if you ask, if you are not driven by the need to heal them, they tell you, "I don't want to be healed. I just want to be listened." Probably because they come from schemas of neglect. So solving problems to them just mean, okay, do it and leave me alone. I don't want to take care about you. But of course, after some months or years, you have realized that that is the pattern. Then you have to renegotiate the contract. Or I may continue just listening to you as long as you want. I just have to tell you that pain won't disappear.
Yeah.
We'll be there. We witness your pain. I'm there with you for as long as you need. But if you want to soothe your pain, I need you do something.
Yeah.
But it's your choice. I'm here, whatever your choice. When you put the contract this way, I don't know, 95% respond. Or 95% of the clients respond.
Yeah.
For example, for years we just were somewhat convinced, as every therapist, that our model worked. Now we are having some data. Okay. There is small randomized controlled trial of the group adaptation, which has been published in Psychology and Psychotherapy, and we have another controlled study, a non-controlled study, a pilot with 17 clients with the same model, another study in Spain, 10 clients with personality disorders, 2 single case series published with personality disorders, individual therapy. I have just completed with Simone Kelly, a colleague from Florence, and Paul Eisecker, a 2 case series studies of people with schizotypal personality disorder. One treated with metacognitive interpersonal therapy, and one treated with Paul's model, the MERIT, metacognitive reflection and insight. Well, overall, what we get is the dropout rates is lower than 10% in general.
So that's one of the big advantages.
Absolutely. Absolutely. For example, we are about to make calculation for avoidant personality disorder, my colleague Shelaine Arzal in Norway, and he analyzed 70 clients with avoidant personality disorders, and I think he just had 1 dropout. And we have to analyze.
Do you attribute this to something, to some specific process? Is it a negotiation? I mean, I imagine it's a lot of variables, but
there are a lot of, my bet would be that we focus on the which.
Okay.
We don't focus on interrupting maladaptive coping, but we focus on that is your goal. It makes sense. I understand you at every level, at the human level. Then there are obstacles, but I want to open hope for you that goal may possibly be met.
Mm-hmm.
Okay, so I don't want mostly dismantle psychopathology, but build health, started from an empathic understanding that your wish is human, is normal, and makes sense.
Mm-hmm.
Then the way you cope with that and your constructions may be problematic, but there is healthy, there is health inside of you. So probably our clients get it.
So and focusing on the wish seems very inherently very validating on one hand.
Absolutely.
And
completely.
Maybe my favorite book is Persuasion and Healing by Jerome Frank in terms of psychotherapy. And I just heard you and I was thinking, well, and this guy, it's very persuasive, it's very coherent, it brings a lot of hope and to the process. So these variables are also there, of course.
Yes.
Yeah. Well, sorry, I interrupted you. You were going to say something.
No, I don't. I think we just have outcome data. We have outcome data which are very promising, and probably support the idea that focusing on the wish and on the healthy self is well accepted by clients.
Very cool. That's very exciting. I want to know more about it when it comes out.
Yes.
In your 2015 manual, you broadly divided the metacognitive interpersonal therapy into kind of two big maps: the shared formulation of functioning, and there was another which was change promoting.
Yes.
So of course we don't have time to go over them, but they seem to kind of very well describe almost two types of works that you're trying to promote in therapy. So maybe trying to focus on just the first broad map, the shared formulation of functioning. Can you say a little bit more about this specific type? It seems to be about aiming to improve the patient's self-reflecting capacities.
Totally, it is.
So what do you think is the main task in this area, in this part of the therapy?
There are some different tasks. The first is promoting awareness of thoughts and affects in the episode, always.
Yeah. Always eliciting specific autobiography.
Always sticking to specific episodes. When you have awareness of thought and affects in the episode, you want to promote awareness of recurrences. That is, that way of feeling and thinking is not just yesterday. It's not just there, but it's something that happens inside your mind.
Yeah.
So you have to ask for associated episodes. It's not association made by the therapist, but it's how it's connected to other similar memories. Okay, and once you got associations, associated memories doesn't mean seeking for attachment history. We just want associated memories. It may be today's memories. Is it connected to the past? No. Patient doesn't have memories. Okay, behavioral exposure. Next memories, awareness of recurrences. So you have new memories and you just have to be aware that the same pattern of thinking and feeling repeats itself over and over again.
Yeah.
Okay. So the ending process, the final state of the formulation is reconstructing these similarities, which is the formulation of the schema.
Yeah.
Okay.
And you mean explicit formulation, like this is co-construct with the client and they know.
Yes. It's shared from everything we do is shared.
Yeah.
If the therapist thinks, probably he or she is wrong. that I learned, for example, from Anthony Bateman. Okay, you must be stupid. And I'm serious. It's a therapeutic goal. Thinking less.
Can you say a little bit more about that?
The more you are consistent with the experience. You just rephrase things that are there in the episode. And you just say, okay, you told this and that, and clients react, oh, well, doctor, but you read my mind. How could you understand me so good? And you're just summarizing the episode.
Yeah.
It's very simple, but the result is great.
Yeah. And this, I believe the last stage in that part is the differentiation, or at least that's where you're headed, to the differentiation.
Yes, and this is the beginning of differentiation. That is, things are not the problem because they are real, but because this is my way of seeing things.
Yeah.
So this is I think this is an element of every psychotherapy.
Yeah.
You can call it finding a way out from the psychic equivalence mode. You can call it diffusion, revising maladaptive beliefs, whatever. We call it differentiation, but the concept is there. This is real. This is my idea.
And once you have that awareness, then is it then that you head on to the change promotion, actually trying to break patterns?
You try to break patterns at any level. You try to break it experientially, you try to break them behaviorally, and then you rewrite them. But rewriting mostly comes from experience. So people are up to do something in session and in between sessions in order to break patterns. For example, during a role play, guided imagery and rescripting, you have the patterns, and then, okay, you are focused on your father criticism. Now try to focus on the way that that football field is so interesting to you, and you are watching your friends playing, and this is so important to you, so you don't mind about your father criticism. You just don't pay attention to it anymore. You are connected to your body reacting to the hunger for the football, for the ball, and for the court. Okay, and that you bring them to a different area. Okay, that's rewriting.
Yeah. Are you informed? Because I'm hearing you, and I was wondering, are you informed in any way by memory consolidation research? Because there seems to be a good parallel with the idea of memory reconsolidation.
Not directly by the clinical paradigm, by the way, the whole issue of episodic memory and autobiographical memory, it has been quite influential to me.
Yeah. One thing I want to ask is, what are the common struggles of your students trying to learn this model?
Oh my goodness. Well, basically, if there are any, they are not allowed to voice them, because they are severely punished if they try to contradict us.
So you are a behaviorist at heart.
Much worse than that. No, okay, more seriously. And I think that there are... I can answer you more from the supervisor position, because I know what is more different to learn. We can teach MIT in no more than 80, 90 hours. We can train a psychotherapist. But then to deliver it consistently and with efficacy, the three struggles are formulation of the schemas, because it is so fine-grained and so individualized that you have to learn all the boxes and to frame them coherently. In particular, being aware of what you don't know and of the healthy self. This is more difficult. But in a way, a good formulation of the schemas requires time and learning first. Then you have to deal with your own person. That is, you are never neutral, especially with personality disorder. You suffer from your own history, and patients call you into reenacting your own patterns, and that create stall. They can create a moment of severe difficulties. And when you brought them in supervision, you realize that it's not the client, but that the client has brought you there in your personal history. So you have to solve that problem. And we do it, by the way, with supervision, with personal therapy. But there is a difficult area to face. And for example, I do live sessions with the trainees during the trainings, and when I ask to the other colleagues, the other students, how did you feel? And many times they are overwhelmed by personal reactions. And facing mourning, abuse, abandonment, they are completely
triggered in their own stuff.
Absolutely, and that is present every session of your life. No matter how experienced you are. I recognize my own issues yesterday. Continuously. And the third issue, which is very important, one of the apparently more shared by every therapy model is the concept of therapeutic alliance. I think, or this is a personal consideration. I have no research background for that statement, but I'm very convinced about that. Therapeutic alliance is about the bond.
Mm-hmm.
Good therapists attend to the bond. The goal,
Mm-hmm.
good therapists form a shared bond. Then there is the task.
Mm-hmm.
The task is often acted or not negotiated. And what I realize in supervision, even with cognitive psychotherapists, is they don't remember that they are not the ones who give the task.
Mm-hmm.
They think about the task, but the task must be chosen by the client.
Uh-huh.
And if the client does not choose the task and does not decide to enact it,
Mm-hmm.
they cannot heal them.
Can you give an example of choosing the task?
Yes. I don't know.
Because when I think of tasks, you literally mean the means to an end. So, for instance,
Yeah.
doing a guiding imagery, for instance, is
For
that
example.
but that's something that you're the first one to invite the idea.
You invite. No, of course, we
Yeah.
constantly invite,
Uh-huh.
but we move forward when the patient says, yes, I want.
So, okay, so it's interesting. You're arguing that the task can be easily neglected. This idea of negotiating the task can be easily
Either is neglected or is assigned
Uh-huh.
without negotiation. And if the patient doesn't do the task, then you as a therapist, you either feel distressed, frustrated, unable, or you blame the patient.
Yeah.
You push them.
Mhm.
Okay. For example, always thinking in terms of relational pain.
Mhm.
You are married with a husband who cheats on you, womanize, drinks, spend your money, whatever, and you don't leave him.
Yeah.
You just stick to the relationship.
Mhm.
Okay. So I don't give you the task to separate from him. I give you the task that day, instead of asking him for the permission to go out with your friends,
Mhm.
you try and do it. Would you do it? And she doesn't do. Then the therapist may become irritated, worried, nervous.
Yeah.
Take the side of the client. No, you have to not consider his will. You have to be consistent with yourself. And the client doesn't listen.
Yeah. So you're trying to
What
force
you
the
do?
task.
You don't force. So that's the task.
Yeah.
What are the reactions when facing this possibility? Then you explore the underlying schemas
Mhm.
for reasons for not being able to perform the task.
Mhm. Mhm.
Most often there is fear,
Mhm.
there is shame, there is guilty.
Mhm.
So if you don't give them the task, you don't get anything.
Mhm.
If you give them the task without negotiation, we don't get anything for different reasons. They just don't do it.
Yeah.
You give the task, they do the task, great. They don't do it, great, because you then explore reasons for not attending the task.
Yeah. Makes
Okay,
total sense.
that's very important, and probably is another key for therapy success.
That's super well lined out. Thank you. That's really helpful to think about it that
Oh,
way.
Great.
I know we're reaching the end of our time. I still wanted to ask you briefly, what are the characteristics that you'd look for if you were to select therapists who would primarily see personality disorder clients? What do you think are the defining characteristics of these therapists independent of their model?
Wow. I would say curiosity,
Mhm.
ability to question themselves, and a certain degree of flexibility,
Mhm.
and having lived a life with different interests. And if you just had a one-dimensional life, you cannot treat personality disorders.
Hmm.
Just as a personal example, when I became a father,
Mhm.
I realized that I started to see things in a much different way, and I became much more tolerant of different perspectives and much less rigid.
Interesting. Yeah.
And if I didn't, probably I would have been a different therapist.
Yeah. Yeah. Mm-hmm.
So if people travel,
Hmm.
and they can see different cultures, and that's helped them.
Yeah.
So I think that is having a certain internal richness and breadth of experience
Yeah.
may be a relevant factor.
Is resilience another one? Because with these clients, it seems like that's an important factor compared to not personality disorder.
Yes, but probably resilience, you build it with training and supervision to a certain extent.
Uh-huh.
You become more resilient over the years as you learn.
Yeah.
Of course, it's just a personal opinion, but interpersonal richness and curiosity and flexibility probably are more internal qualities.
Yeah. 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 Yeah.
And but maybe resilience, it is something that you have to have before doing that.
Very interesting.
And by the way, and you have to be a bit aware and to a certain extent free from your own schemas.
Sure.
Of course, you are never free from your schemas, never.
Yeah.
Okay, but to a certain extent, you have to have them here,
Yeah.
in front of you, inside your hands.
The detachment.
Face them.
Yeah.
Exactly. Yeah. So probably it was not caught by the camera, but
No, but yeah. So I mean, I have one final question for you that I asked all of our colleagues when I did these interviews, and I wanted to ask you what advice you wish you'd had received when you were starting out your career as a psychotherapist.
oh my goodness, I probably had very good advices. Probably I was not able to listen in my early years. I was quite stubborn to a certain extent. And for example, I didn't want to have a psychotherapy training school.
Mm-hmm.
I just thought I was very arrogant. I have to admit that. I learning. I'm studying a lot of books. I can understand the theory. So why do have a psychotherapy training where people try to force my mind into that direction? And of course, I completely changed my mind. I had kind of 4 different trainings: cognitive, interpersonal psychoanalysis, psychodrama, constructivist, and whatever. And some mindfulness in recent years. So I completely changed my mind. Probably what I needed is watching what seasoned clinicians do.
Okay.
One of my first mentors, it is not famous worldwide, is a group and family therapist, Corrado Pontalti. He was very important to me. And because we could see his sessions and discuss them. Mm-hmm. We watched outside one-sided mirror, and then we discussed for 2 hours family sessions with personality disordered families. Yeah. And that was an incredible learning experience. So it is not about my manual says that, but this is what I do.
Yeah.
For example, during the Dialogical Self Conference this year in Braga, in Portugal, I saw a video by my friend and source of inspiration, Bob Dimaggio. I just saw it and say, wow, this is beautiful. It was creative. And you can convey what you do in your session if you don't show what you do.
It's like trying to describe a painting. Yeah.
Exactly. You have to show the painting. And then you learn from the texture, the colors, exactly. Or you cannot describe jazz rock improvisation. You have to listen to it.
Exactly. Giancarlo, I just want to say, it was such a cool pleasure to have this chat with you. Thank you so much.
Same with me. Absolutely. Thank you very much, Alexander.
Thanks so much, Giancarlo.